So hi everybody, how are you? Are you bored?
No, sir.
No? Okay, that's great. So so last time when I started, I think that 2 days back, this is a neurology. Okay. So in neurology, how many people were joining yesterday? Two days back, two people, right? Dr.
Yes, sir.
Archana over here and Dr. Priyanka.
Yes, sir. Dr. Archana is here.
Okay, okay, great. So first, so I had taken one CCS and 10 CPA.
Dr. Saif, sorry.
So I
The sound, I think the sound is a little bit far, or this is my problem.
oh, little bit far. Okay, just let me look at the settings.
Same here.
Now, is it clear?
Yes, sir. Better.
Yes,
Now, now my clear, huh? Because I've changed the audio settings to some
Better, yes, yes.
other microphone. Okay. This is okay, huh? Are you able to hear me clear and crystal, right?
Yes, sir.
Yes, better.
Okay, great.
Yeah.
Better? Okay. Fine. So I will quickly go through the CCS questions. Okay. And this case, which I'm going to debrief here, was a kind of a near real case. Okay, about 90% near real case. I mean, which was asked in the last exam in EDIC part 2. Okay, so I'll just go through very fast. So I mean, this is the one. This is for ones who joined my session 2 days back. So this is just a case of subarachnoid hemorrhage. So this is history, vital signs. You can see vital signs. There is hypertension. This patient presented with very typical headache. Okay, with hypertension, and GCS was a little bit low, 11, and there was no focal neurological deficit, but there was neck stiffness present. And vitals were otherwise fine, but only hypertension, 180/110 of blood pressure. So this was a little bit of history and examination findings. And with this, questions were like this. Okay, so provide a list of 3 grading scales of subarachnoid hemorrhage. So you should know the grading scale. So you know the clinical grading of SCH is very important to prognosticate the patient's outcome, and also to identify the complications. To so the risk of complications in SCH also more or less depends on the clinical grading. So these are 3 clinical gradings. You know very well the Hunt and Hess, very old WFNS, that is World Federation of Neurological Surgeons, and Fisher's CT grading, and Fisher's modified CT grading. So there are 4 basically. But the most widely used is the WFNS clinical scale, which is very simple to use and everybody remembers this very easily. So as per this scale, our patient is grade 4. Okay, the GCS 7 to 12 with no without or with deficit. So this is grade 4 SAH in our case. Okay, but just for the sake of knowledge, you should remember all these scales which may be asked in exam. What are the 2 immediate active issues in this patient warranting critical care referral? So aptly answered by the aspirants, Dr. Archana and Dr. Priyanka both. So high ICP and hypertension, vasospasm, these are immediate active issue in this particular patient, so which need immediate attention and management. The next question was initial investigations. So routine blood, but what you forgot was the NCCT brain. NCCT brain is first and the most commonly used imaging investigation to detect the SCH, even to grade the SCH. And if it is inconclusive, if suppose NCCT is not able to make or detect SAH or make the diagnosis, you have to go for LP. Okay, and in this case, patient had neck stiffness, so definitely go for LP. And LP will be able to show you xanthochromia and the make a diagnosis of SAH to confirm the diagnosis. But for the localization of source of bleeding and to plan the neuro interventions in the form of clipping or coiling, you have to have the SA or CT angiography or MRA. DSA is the gold standard for planning further interventions. So these were imaging things. Now you need to have a ECG. You know why ECG? Everybody knows that ECG is important to detect the STT changes, because SAH is a kind of cytokine storm condition. Like SAH leads to activation of sympathoadrenal system. So it causes kind of it induces kind of stress on the body's and organ systems and can lead to stress cardiomyopathy and STT depression, STT elevation, or even depression. All STT changes can be seen, even arrhythmia, SVT, VTAC. We have all kinds of arrhythmias have been seen, especially tachyarrhythmia have been seen on ECG. So ECG is very, very important. And apart from ECG, you have to go for echocardiography as well. But that is not urgent investigation. But you can still mention it. Okay. And suppose CT angiography is not possible or DSA is not possible, you have to go for MRA. All right. So these are initial investigations. Now, early complications. So you need to know the complications in SAH. The most common ones are, the rebleeding, hydrocephalus, and vasospasm, delayed cerebral ischemia, infarction, etc. So you need to remember complete list of complications of all the important critical care illnesses. Okay, and how do we monitor them, and how do we detect them, manage them? All these are very interesting to know. And also don't forget to answer one by one. Give a list. Suppose somebody is asking you 2 or 3, give a list of 4. I mean 4 or 5 things. Don't explain. If somebody is asking you, okay, just give me particular question, particular answer, specific answer to some question, just give in points, okay, and finish in within 1 minute. So that is the practice you need to do as far as EDIC part 2 is concerned. So in this case, early complications means less than 4 days or less than a week are the rebleeding, seizures, and hydrocephalus. Hydrocephalus can be acute, subacute, or chronic also. And seizures can be early seizures or late seizures also. Okay, especially in traumatic SCH, it could be early and late. But as far as early complications are concerned, rebleeding, seizures, and hydrocephalus are the ones. And somebody asks you late complication, you can still quote hydrocephalus, but the most common late complication is the vasospasm. I mean the cerebral vasospasm. That's the late complication most of the time, and infections. Okay,
Sir,
so
but we have discussed the vasospasm, the immediate complication, sir.
no, it is late usually.
Three slides back, sir, we have discussed immediate complication, vasospasm.
Immediate complications.
Yes, sir. 3 slides back we have mentioned, sir.
All right. Okay. Sorry. Here, usually it is late complications. Where we have mentioned here, active immediate.
Yes, sir.
Active issues could be possibly. See, in few patients it could be vasospasm. In this patient particularly, you can say in this patient particularly, we don't know whether patient has developed vasospasm. So not as far as this the information on the slide is concerned, you cannot say this is vasospasm, right? You have to do certain investigation like TCD or something like CT angiography to detect vasospasm. It is quite difficult to say whether the patient has vasospasm, but it is not early complication. So I'm sorry for that. This is not okay, but yes, it may be possible. In 10% cases, vasospasm can present as active early complications of SCH. Okay, especially the high grade, grade 4 or 5 or CT grade. It can present as vasospasm. If the blood amount of the blood is more and it has clotted already. Okay, so it can, suppose the blood has clotted, it will lead to hematin, the iron outside the clot, and it will irritate the blood vessels and will lead to vasospasm. That is the possibility if patient is having severe kind of SCH, but not to mention here vasospasm, better high ICP and hypertension. And drowsiness are the active issues. Patient may develop a drop in GCS in next few hours. So this could also be immediate active issue warranting critical care referral. All right. So you have to just use your brain and give the answer. That is not, difficult. That's not going to be difficult. Okay. So shall we go ahead? Is there any doubt? Any candidate having doubt here? Okay. Shall we go ahead? Okay. So CT scan of this patient showed hyperdense area, and angiography showed 7 millimeter anterior communicating artery aneurysm. Otherwise, other investigations were normal. So, what were the questions? So, list 4 early management strategies in this case. So, somebody asked you early in management strategies. So, first of all, you have to just monitor and stabilize the vital parameters, which were aptly answered by all the candidates. BP monitoring and control is crucial in this patient because you have to prevent the rebleeding. Still, the aneurysm is unsecured. You have not done any definitive management for that. So you need to target SPP 142, 160 millimeter of mercury. Okay, and ICV monitoring and control is also indicated, though guidelines say guidelines are not very clear about ICV monitoring in SCH, but they say if GCS is dropping, okay, GCS is say less than 9, you have to start ICV monitoring and control it. Okay, and few guidelines say, few papers I read, they say you have to place EVD if there is ventriculomegaly, okay, obstructive hydrocephalus. Definitely you need to go for EVD insertion. So that is up to neurosurgeon. And feature prophylaxis, again, the guidelines are not very clear about whether to start anti-seizure medications, but still you can say, because these are the kinds of best practice points. So you can still say, okay, for prophylaxis, I need to start seizure prophylaxis. These are the risk factors, but nobody is going to cut your marks if you see some point. Okay, if they don't agree, they will not give you. Suppose you answer something which is fitting in their screening of answers, definitely they will give you marks. So you have to speak more points. Okay, so seizure prophylaxis is controversial, but there are risk factors for seizures. We'll discuss it later. Okay. What are important measures to prevent rebleed? So the first and foremost, you need to say secure aneurysm by either employing the new radiological interventions, okay, interventional radiology, coiling or embolization, or you need to go for clipping. And BP control is must. You need to target systolic blood pressure between 140 to 160 millimeter of mercury. Regarding antifibrinolytics, again, the papers before 2015, even 2018, they were saying that antifibrinolytics should be given, especially in early cases less than 72 hours. But the recent papers and recent meta-analyses are again saying that there are not robust data to advocate their uses, antifibrinolytics. So the Lancet study, latest published, this editorial basically has suggested not to use antifibrinolytics because the evidence base is not strong to use antifibrinolytics, okay, in SH. But still, you can mention antifibrinolytic because they are not going to cut your marks if you say something which is not in their answer list. List 2 commonly used drugs to control blood pressure in this patient. So don't say anything which is being practiced in your institution. Okay, don't say that it is usually or commonly or widely. Don't say those words. What is there in the guidelines? What is there in the evidence which you have enough evidence to suggest some therapy? Definitely you should answer those therapies. Otherwise, I think don't comment. Okay, because that may be. So here, what do you think? What should be the drugs to control the blood pressure?
Labetalol.
Labetalol,
Yes, very good.
Nicardia,
Yes, nicardipine,
calcium
hydrolysine,
channel blockers. We can
calcium
use.
channel blockers, definitely. And any other? So you can use beta blockers, this calcium channel blocker. Labetalol is the best, obviously. This is the best and first and foremost drug. Hydrolysine is available in Western countries. Hydrolysine is very easily available. Even AC inhibitors are available, so you can use AC inhibitors. But never use, avoid what? The nitroglycerin. Okay, avoid sodium nitrophosphamide. So vasodilators should be avoided because they can cause cerebral vasodilation and increase in ICP. You definitely don't utter, right? Even if you utter, I mean, they are not going to cut your marks, but definitely the impression will go wrong if you say something which is contraindicated or avoid, in the list of avoided drugs. Okay, these are things. Nimodipine, you can say this is cerebral vasodilator, but it is available as a oral form, no IV nimodipine. Still it is being used to prevent vasospasm, you can say that, but not to control the blood pressure. Okay, so nimodipine is out of the list. I'm sorry I mentioned here, but this is not the drug to control the blood pressure. Okay, what are two benefits of endovascular treatment in this case? So it is in general. In general, endovascular treatment is favored. Okay, but you should know various benefits also. So what could be the benefits? So surgery is avoided, craniotomy is avoided, less hospitalization. Okay, and minimally invasive. All these are advantages. Reduce surgical risk, quicker recovery, suitable in high-risk patients who have multiple comorbidity, and higher survival free of disability after 1 year. This is ISAT trial. So you can quote ISAT. I mean, one of my our candidates mentioned ISAT. So ISAT guidelines you should read about SAH. So they have mentioned various interventions, various drugs, various things about SAH management. So you should go through. And so as per ISAT, higher survival free of disability after 1 year with endovascular treatment compared to clipping. Okay. What are two main indications of surgery in a case of SH? This is also important. So you should know the indications and you should know the disadvantages of surgery. So what are the indications? So indications are if the surgery, if the aneurysm is very wide neck, has wide neck, or if the coiling is failed, or if it is recurring, the recurrence of aneurysm, recurrence of bleed, and complex aneurysm. So these are the kind of technical issues for which the surgery is indicated usually.
Hydrocephalus.
Hydrocephalus also, yeah, if it is severe hydrocephalus, even in case of hematoma, if there are multiple hematomas, ICH, a patient is presenting with SDH also, ICH. In such cases also surgery is indicated. You are right, very nice.
Hydrocephalus as a complication of SH, then surgery can be done.
Yeah, surgery has to be done. Yes, great. Okay, what are two main cardiovascular complications? So this already has been underscored in previous slides. Arrhythmia, SCT changes, troponin, anti-proBNP elevations, so for which biomarkers have to be done, and stress cardiomyopathy is also a complication. So this is VNet 3. So this particular patient was admitted to neuro ICU. Labetalol was started to maintain the systolic blood pressure to control it, and neurosurgery, consultation was obtained, and they did the clipping. So they favored clipping due to some reason. Okay, in this case, and when patient was inside the OT, all the means to secure the aneurysm were unsuccessful, and without securing aneurysm, patient was transferred to neuro ICU for post-operative care, and his patient is intubated, sedated, on ventilator. So with this information, now questions are, what are two preferred sedative for use during mechanical ventilation in this case? So very commonly, okay. So will you choose midazolam in this case? Yes, no. So something which is called preferred, something which is called ideal, okay, something which is called level 1 sedative. So preferred meant which you are using, okay, or for which there is good evidence
Propofol,
to use.
thiopentone can be used.
More benefit than the harm. So thiopentone, so better if you use a sedative which can be stopped and you can assess GCS. Okay, so such kind of sedatives are better in neurological cases. Here also you need to use something like propofol, okay, or dexmedetomidine or remifentanil. All are these ideal or preferred sedative or sedatives of choice in case of SAH. So this is a very nice paper again, a scoping review in which they have mentioned dexmed and propofol and remifentanil are the ones which are preferred. Okay, but midazolam is not favored. Okay, midazolam is, even if patient is having seizure, you start anti-epileptic, but don't keep the patient on midazolam. Now, what are 4 immediate post-operative principles of management in SAH in this case, especially? So here you have to control ICP, you need to control blood pressure. Yes, very good, because still the aneurysm is not managed and the seizure has to be controlled, vasospasm has to be prevented. Now, what modalities of neuromonitoring you would apply? So these are various. So you should know in and out of neuromonitoring, the list of the gadgets, clinical monitoring, and the interventional monitoring. So you should know the list of. So this is hot. Okay, neuromonitoring is hot topic.
We can add TCD, sir.
Yeah, sure. ICP, TCD. TCD is also nowadays is kind of, we can have a continuous monitoring. So TCD is also a very good option, a very good thing. And brain tissue oxygen monitoring, cerebral microdialysis. You should know a little bit of CMD also very, very important nowadays. And cortical EEG, continuous EEG. You should always say, although it is not very commonly used even in Western countries, but it's still in all neurological cases, what is suggested or what is recommended is the continuous EEG to detect a non-convulsive state of affections. So you have to avoid further secondary brain injury. Now, what are the 2 ICP reduction strategies? Again, this is hot topic. ICP reduction. Any neurological case, you will get at least 1 or 2 questions on ICP reduction strategy. So you should know level 1, level 2, level 3, all these. So this is the monitoring, monitoring techniques. Okay, various monitoring techniques, neuromonitoring, HAVO2. So basically, brain oxygenation, brain metabolism, ICP, brain perfusion, 4 things. Okay. So ICP reduction, you have to, you can drain if there is a chance that you can drain the CSF. If you have EDT, then lumbar puncture can be done to drain the CSF to reduce. If all the interventions, to control the ICP have failed already, you have to go for all these barbiturate coma and decompressive craniectomy. So these are various tired therapies. So tier 1, tier 2, tier 3, tier 4. ICP reduction therapy. So tier 4 means that this is refractory, intracranial hypertension, and you have to go for either decompressive craniectomy or barbiturate or even EVT. Okay. And you can mention hyperventilation, but hyperventilation is for only very short period of time, about 6 hours. It will just buy you some time. So this clip, this image, I have obtained from this paper. How I manage. This is very nice. Okay, you can read it. All these articles are really very, very interesting. It will definitely change your practice. Okay, to change you manage the patient. So this is very nice. How I manage intracranial hypertension from Dr. Rabba. So this is so they have mentioned, these tiers of therapy, and this can be asked in exam. Okay. Now, VNet 4. After 24 hours of stabilizing PP and ICP, patient successfully underwent endovascular coil embolization for the ruptured aneurysm. Post-procedure, the patient was monitored in the neuro ICU, and 6 hours later, patient was extubated. GCS was 11. So this is good. This is now back to 11. Okay. Now, how will you monitor cerebral vasospasm? So what is the best way? Okay, so you can use
TCD monitor.
Yeah, you can use TCD. You can use cerebral, angiography also to monitor, and clinical monitoring also can be done. But TCD is very good. So, what are two main predictors of delayed cerebral ischemia?
So decrease in GCS, sir. Clinically.
So clinical, yes. So clinical is always best. So main predictors, if the grade was already bad, if there is thick blood on CT or clinical grade was bad, okay, very worse. So that is main predictor. Fisher's grading is also important. And then they have mentioned if there is presence of intracranial hematoma, okay. So other than SCH, if there is hematoma, or if there is high D dimer levels, okay. If there is high D dimer level, that is they have not given a cutoff, but it's the high. I don't know how high, but this is one of the main predictors of related cerebral ischemia. And modified Rankin scale, that is one of them, and neutrophil to lymphocyte ratio. But you can always see clinical and CT ratio and presence of multiple, the requirement of multiple surgery, all are a delayed presentation. So all are the main predictors of the cerebral ischemia. Okay, what are three main drawbacks of hemodilution and hypertension? This is a very interesting question. Okay, so the triple H therapy has been abandoned because of the drawbacks. So the main drawback was increased risk of complications. So hemodilution and hypervolemia can lead to volume overload, the signs of volume overload, pulmonary edema, electrolyte imbalances. So due to this reason, it is abandoned, and lack of efficacy. So no outcome study has shown benefit of triple H therapy. Okay, so there was no benefit, lack of efficacy, and higher mortality. So they could show the mortality was higher with triple H therapy. So only hypertension, induced hypertension was, was kept, okay, and hemodilution and hypervolemia were omitted from triple H therapy. So what we practice is just induce hypertension after clipping or coiling has been done. Now this is at 5, initially stable, her conditions worsened on day 2, GCS dropped to 7. So she required reintubation, and patient was hooked to mechanical ventilation. Repeat CT scan showed a rebleed and hydrocephalus. So nimodipine was continued, TCT was started, monitoring was started, and EVT was placed, okay, and seizure prophylaxis was started. So what are two benefits of using TCD monitoring in this case? So the answers are that you can, this is a non-invasive, this is a Doppler, so it's non-invasive monitor. It can be repeated multiple times, but this is operator dependent. So just to remove the operator dependence and improve the validity, what they are doing nowadays is the continuous TCD monitoring with the special Doppler thing which you can put on the forehead and use the and then monitor the cerebral blood flow, the MCA velocities. Okay, so TCD is good because it is cost effective, it can be repeated, and it is non-invasive. Okay, non-invasive continuous cost effective. Now, what are two main complications of EVD placement? So you need to know the complications. So
Sir, you asked me what was the goal of MAP? I mean, what was the goal for induced hypertension?
No, I asked you what was the target of systolic blood pressure, to control the blood pressure before securing aneurysm. Remember? So somebody said we will keep 130 systolic. So that is okay. But 140 to 160 is. But target, suppose you are inducing the hypertension in case of SDH, what will be your target? Okay. Now let me discuss this. Yes, Dr. Priyanka.
Before securing the aneurysm will be below
After.
160?
Yeah, after securing.
Before securing below 160?
Yeah.
And after securing below 180?
Below 180. Yes, that's okay. So 160 to 180, you can target after securing aneurysm. So what will you use for inducing hypertension? Are you doing this in your institution? What are the guidelines?
Yes, sir. We have done it. We use norepinephrine only. We can use norepinephrine. The target is around 140, 160 after securing. So what is the target before securing the aneurysm?
Before securing aneurysm, the target is 140 to 160.
Sir, 140 to 160 is after securing the aneurysm.
After 160 to 180.
You can have a delayed cerebral ischemia also. So we keep the blood pressure high only.
That's what. But we don't allow more than 160. We don't allow more than 160 before securing aneurysm. But this is very vague. I mean, there are not definite. If you have any definite trial or something, you can quote. Is there any guideline which say less than systolic blood pressure less than 140 is better than less securing targeting systolic blood pressure less than 160? Anybody? Come on. Okay, no problem. So we will. So you can just like go through it. If this is like controversial, or if you have, or if even I will go through it. Okay, it's all right. What are main complications of ED placement? So you said infections can occur, bleeding, catheter malposition is one of the complications, and also drain failure. List 3 main complications, main risk factors of seizures. This is also important. What are the risk factors? So you will not start anti-seizure medication in all cases. So what are various risk factors? Okay, so rupture of anterior circulation aneurysm is more likely to cause seizure. Surgical clipping compared to coiling. The patient is has undergone clipping, there is high risk of seizure. So you should start anti-seizure medication. And presence of intracranial hematoma and recurrent bleeding are also risk factors of seizures. So now we get 6. So patient condition continued to worsen. On post-operative day 4, she developed worsening neurological status. Jesus worsened to 40. Repeat CT scan showed significant increase in the size of hematoma, further expansion of the ventricles. She underwent urgent craniectomy, and intraoperative findings revealed extensive blood clots and severe cortical edema. Post-surgery, her GCS score improved to 8 by 15 but low, prompting close monitoring in neuro ICU. She was continued on supportive care. Despite all these interventions, neurological examination remained concerning, and she developed fever suggestive of possible infections. Now, critical care team remained vigilant, collaborating with neurology and infectious disease team to optimize her care. The family was kept informed of her precarious situation as they grappled with the uncertainty surrounding her prognosis. So this was the kind of real vignettes. And with this, the questions were, what are 4 main causes of fever in this patient? So a fever in neurology is also very interesting. In all neurological cases, common causes of fever, more common causes of fever are usually non-infectious. Okay, but in this patient, particular patient, because patient has undergone surgery, and interventions, and patient is already in ICU since last 4 or 5 days. So there are various other causes. Okay, so infections could be one, which could be because of the CNS infection or pneumonia, UTI, and there could be a systemic inflammatory response syndrome leading to fever, central fever. Okay, some of you have answered this central cause of fever also, which is very impressive, and hydrocephalus. Okay, thromboembolic infarction, thromboembolic causes infarction, ischemia can also lead to fever. Okay, so many various causes of fever in case of SH. Now, what are 3 risk factors for nosocomial meningitis? The patient who have undergone surgery, they can have
EVD placement.
Yeah.
Lumbar puncture.
Lumbar puncture. So hardware, basically device. Okay, so there is device, there is a opening, fracture, or surgical trauma. All these can be risk factors for nosocomial meningitis, or even immunocompromised state can also lead to meningitis. Okay. Prolonged hospitalization, presence of sinusitis, presence of shunts, okay, central venous catheters, all can lead to nosocomial meningitis. All right. Now, what are 3 first-line antibiotics?
So is there presence of what before?
Presence of shunts and central venous catheter, ventriculoperitoneal shunt, EVD.
Shunts, thank
Yeah.
you. Sure.
Okay, yeah. Devices, so hardware. So that is what we have discussed already. So any invasive procedure, any surgical trauma, nosocomial meningitis. So what are 3 first-line antibiotics for nosocomial meningitis? So 3rd generation cephalosporin, we have said already, vancomycin are the first line. But if suppose patient is immunocompromised, then you have to use ampicillin, okay, to cover for monocytogenes, Listeria monocytogenes, or you can use ciprofloxacin if you're suspecting pseudomeningitis, and or post-operative meningitis. And you can, suppose patient has already stayed for more than 7 days, then meropenem, ceftazidime are better choices. Okay, meropenem also can be used, but all these all can be modified based on antibiotic. But we are just talking about the first 3. Then we have the intrathecal, intravenous, and the blood-brain barrier penetration, all these issues, meningitic doses, etc. Now, what factors predicted poor neurological outcome? So again, you have clinical grading, the WFNS grade, officious grade. Then age, older age carries poor prognosis. This is the paper. This is a systematic review and meta-analysis where they have accumulated all the risk factors, and they did this multivariate analysis, regression analysis, and they found various odds ratio, adjusted odds ratios, and these are the various grades. Okay, I mean various risk factors, various factors which can predict the outcome by poor outcome. So older age, presence of intracranial hematoma, preoperative rebleeding, the presence of EVD or EVD requirement, delayed cerebral ischemia, all are associated with poor outcome in SH. So outcome also is very important in critical illness. Okay, so if you have any case, definitely one of the questions will be on outcome. You should not omit it when you are studying. You should know few predictors. Now, what are the main predictors of tracheostomy? So in this case, probably tracheostomy will be required, okay, because patient is GCS is poor. So again, various risk factors are possible. Again, same risk factors: presence of hydrocephalus, higher grade, clinical grade, decompressive craniotomy, sepsis, older age. So these are main risk factors for requirement of tracheostomy in case of SAH. Okay. So with this, CCS was over. Now we go to quickly the neuro CPA. So I kept 10 CPA. Okay, so quickly we'll go through. So this is a very good case of, what was the case, Dr. Archana? Is still with us? The Dr. Archana aptly recognized this case, the diagnosis. So this is the case of rhabdomyolysis. So what are the main steps of management in case of rhabdomyolysis? So you have to provide hydration as you provide in case of TK or acute pancreatitis. The same way you need to provide, you have to administer a lot of IV fluid.
Alkaline diuresis.
Alkaline. So there is something called alkaline diuresis, something called forced alkaline diuresis. So you need to just say that I will give hydration. Okay. First, hydration is more important. Then you say, okay, there is a hyperkalemia and acidosis, something add some soda bicarbonate. So that will become alkaline hydration. And then you have to have some good urine output. So you monitor for urine output and say that you need to have at least 100 to 200 ml per hour of urine output. That is the diuresis, which you will aim to prevent any pulmonary edema. Otherwise,
Sound is little bit far, sir, again, huh?
Oh, I'm sorry. Now, is that okay?
Yes, sir.
Okay. Sorry for this. So the steps of management, the monitoring is more important. So what you have to include in management, not only the treatment, but also the monitoring. Okay. Management consists of the detection of complications also. The management also consists of the treatment, therapeutic, and also it consists of the monitoring of various complications due to treatment or due to disease. So don't forget monitoring. So we need to regularly monitor the potassium, the CK level every day, and urine output, of course. Okay, in this case. So this will constitute the management and differential diagnosis. So the differential diagnosis of rhabdomyolysis can be again any muscle disorder. Okay. So myositis, inflammatory myositis, you can say one could be differential. Second, you can say in this case the compartment syndrome. Okay, leg compartment syndrome, which can also give rise to pain and maybe weakness, and hyperkalemic paralysis. This is one more differential. Patient had normal body temperature, so malignant hypothermia may not be good differential in this case. Suppose the temperature would have been higher. In this case, the differential would include the malignant hypothermia as well.
It should be in use, maybe.
Yes. Okay, this is the second question. So just to look at the CT scan. So this patient is very young and developed deficits, neurological deficit, decreased level of consciousness. GCS is 40. Powers are bad in left side, low power. So what could you expect in the CT? What is the finding? So it is very difficult to say at first look, but if you closely look here, okay, so this is hyperdense, this is basilar artery. And if you look at this thing, this part, this is the brainstem. Okay, so looks like that this is hypodense, but very difficult to say. This is why. So this is one thing where you can disagree with me, that is, the diagnosis of basilar artery syndrome, basilar artery occlusion. So this is hyperdense basilar artery sign, which appears as a focal area of increased density within the basilar artery, as I showed you here. This is your basilar artery, which is hyperdense, and hypodense cortex. Okay, so basically this is the case of basilar artery, acute basilar artery occlusion, and it can lead to locked-in syndrome later. If suppose somebody asks you what is what is the next line of imaging you will perform? Even if you have not said here the basal artery, if you are not able to diagnose, CT looks normal to you, then what will you do? So you have to go for MRI to look for the wake up stroke. Okay. So next line of imaging you would perform in this case. Suppose this is not a basal artery syndrome, you would go for MRI and MRA. But in case of basal artery, you have to go for angiography or CT perfusion, which will definitely give you the confirm your diagnosis of basal artery thrombosis. Okay, this was the third CPA. So in this patient was aggressively treated for hyponatremia. Sodium was 103, and they gave a lot of normal saline and 3% saline also, and sodium went up to, they jumped to 141. Okay, the patient became developed the dysentery and all. So if you look at MRI, this is MRI cut. So there is
Cerebral pontine myeloma.
hyperintensity. Yeah, so this is central pontine myelinosis. So we were discussing risk factors. So you should know the risk factors. That is very, very important. So there are a lot of risk factors. Alcoholic is one of them. Cirrhosis of liver transplantation, malnourishment, hypokalemia, Burns patient. So these are various risk factors. Okay, so this was the question. Now, what is the diagnosis here? So look at CT scan. There is some, hyperdensity.
Chronic subdural hematoma.
Yeah, so it could be chronic, it could be acute. How will you see that this is acute, not chronic?
Acute will be more hyperdense. It will be more whiter than the hyperdense than the chronic.
Okay. Good. And there may be little bit stages also. Some blood will be clotted. So
Yes.
if the blood is clotted already, it will not be as hyperdense. Okay.
Yes.
So fresh blood is hyperdense.
So, but
already. So there may be
history may there is history of fall. I mean, it will be acute only. No?
acute one. Yes. So this is acute. Okay. This is acute because this patient was on oral anticoagulant. Okay, so this is one more important risk factor which led to large subdural hemorrhage, and also the neurological deterioration was quite acute. Okay, and there is increase in ICP. So this is acute acute STH. So this patient has large right-sided subdural hemorrhage, which is not limited by cranial sutures and seen all ages. So this is important. Acute subdural hemorrhage is typically a homogeneous hyperdense extraxial collection which can have areas of unclotted blood causing mixed density within the hemorrhage. So there are mixed densities. So in this slide, you may not be very, you may not be very clear about the hyperdensity. This is not very clear picture basically, but this is hyperdense, little bit hyperdense. Okay, so I'm sorry about the image, but image is not very clear. But if you look at the history, this looks like acute.
Acute on top of chronic, and it
And
looks
how do
like all ages, huh?
Yes, all ages could be acute on chronic or maybe possibly some chronic, but the chronic should be, there should be demarcation of chronic and then acute. So anyway, if you say right-sided subdural hemorrhage, that is fine. If you are saying acute, then you have to go for surgery, right? So the management, the question was about management also. So how will you manage this case? Obviously, you have to take the help of neurosurgery, but you cannot do neurosurgery. So what you are going to do first is to reverse the anticoagulation. So you have to use some reversal agent and correct the INR. Okay? That is very, very important. So how will you reverse the anticoagulation with the comodins?
Vitamin K, sir.
Vitamin K
BCC.
BCC.
and transfusion of an FFP.
Because we need it
transfusion.
fast.
Yes,
BCC
is very good.
Vitamin
Exactly.
K will delay. Yeah, we
Yeah,
need
it is for
urgent.
chronic.
BCC.
Yes, you're right. Urgent basis, because there is a drop in GCS and all, patient will be intubated. So definitely PCC is better choice here. The PCC and FFP both you will use for reversal. and go for neurosurgery. This is very interesting. Nobody could make out. Okay, what is your diagnosis? I will give you a moment.
Press.
Press syndromes.
Very good. Who said press? No.
Sir, I later on I remembered it. Press.
Okay, Dr. Priyanka, very good. So press. So press is why press? Why do you think this is press?
Sir, these are hyperintensities in the occipital. They are bilaterally symmetrical and
Hyper MRI.
Okay. Yeah, later on I
In history, this is a post-operative heart transplant. Okay, so in heart transplant, they usually start on tacrolimus, which can lead to hypertension. Okay, so this could be because of that. So
Sir, but you have not mentioned hypertension. Actually, vital signs.
No.
So this
Stable, I said unremarkable. But usually this is the case. Usually this could be related to the hypertension and tacrolimus, etc. But if you look at MRI alone, this is related. I mean, this is very suggestive of the press syndrome. So what will you do for press?
Control of BP, sir.
Blood pressure control.
Blood pressure control and anything else? So tacrolimus, suppose patient is on tacrolimus, you need to change to some other immunosuppressant. Okay, that is also one more thing. So you can use IVIG or you can use low dose of steroid. Even a steroid can cause hypertension. So usually just stop tacrolimus. Steroid also you can reduce the steroid doses and start something like IVIG. Okay. Any chance that patient may have a viral encephalitis in this case?
So there will be temporal announcement in that case.
So that was exactly the next case. Okay, I will show you later. So this is the poor press. Okay, poor press syndrome. But what are differentials? So there are a lot of differentials you can see in this. You can take a screenshot of this very nicely. This is an article from NHA. So it has given a lot of differentials which can be kept in mind while you are diagnosing or thinking of press. So demyelinating diseases, brain tumors, CNS infections, edem. Edem is also one more important differentials, and toxic encephalopathies. Okay. So MRA and MRB have to be done. Okay, to rule out all these differentials. Okay, this is another case. So this is a patient who developed stroke and
burst suppression.
So this EEG was done because of profound stupor. Patient had this profound stupor. EEG is done, and neurologically, patient has symmetric reactive pupils, right gaze preference, upper motor neuron facial droop on the left, focal deficit. Okay, so with all these things, EEG was done. What is your diagnosis? So there are some epilepto. So EEG may be kept in exam. Okay, so don't forget EEG. So you have to recognize the features of where there are typical features of hepatic encephalopathy. There you have to recognize the epilepto discharges. You have to recognize the normal EEG waves, alpha, beta, theta, delta waves. Okay. So what do you think? So these are normals, but these middle waves are abnormal here, which are quite high spikes, high amplitude spikes. Okay, so with this you may think that this could be epileptoform activity, but actually this is not epileptoform. This is called periodic lateralized epileptoform discharges, PLED. And PLED, they say that it is commonly seen in ischemic stroke, tumor infection, hemorrhage, etc., even metabolic encephalopathy, and it does not require any seizure, anti-seizure medications. So only primary, treatment of primary cause is all required in such cases, in case of PLED. So this is something which is important. PLED. need not require anti-seizure medications. Okay, this is another case. Patient had neurological symptom. LP done. LP shows findings. Now MRI is done. MRI shows this thing. What is your CSF finding? What is your MRI finding? What is your management?
Viral meningoencephalitis.
Viral meningoencephalitis. Very good. So which viral specifically this is?
It can be HSV1, 2, can be
Herpes simplex NK.
Yeah, HSV1, 2, or VZV. Okay, so herpes family encephalitis. There is temporal enhancement. So, and CSF analysis also showed there is normal opening pressure, clear appearance. So this is important to get. CSF close glucose is not, but protein is not high. Okay. So this is viral encephalitis, HSV encephalitis. Treatment is encapsulate
antiviral for 21 days.
14 to 20.
Yes, sir.
Okay, so this is very straightforward. Now this is again one more question on EV, ICP monitoring. Okay, so during ICP monitoring through EVG, there was this sharp rise in ICP for some period of time. So what is this?
Increased IC.
So this was
Lundeberg, sir.
very good. So you have to remember exactly. So you have to remember all the tracings, all the abnormal tracings in ICP. This is important. So Lundberg A wave, which are usually pathological. Lundberg B wave may be pathological, may not be pathological. Lundberg A wave are high amplitude for longer duration of time, about 10 to 15, 20 minutes. And Lundberg B waves are shorter, less than 5 minutes, okay, and a small amplitude and a little bit high frequency. But that could be associated, Lundberg B could be associated with vasospasm. This is the significant. And Lundberg C are normal waves. So usually in exam, A and B will be asked. A and B could be asked. That's why we have kept this here. Okay, this is another question, which is from neuromuscular part of neurology. Here patient came with weakness, okay, and eyelid drooping of left eyelid, fluctuating blurring vision, and dysarthria, left-sided facial weakness, dysconjugate gaze. Pulmonary function tests are normal. EMG is this. So what is there in EMG? So this is the repeated nerve stimulation, RNS.
Myasthenia gravis.
Myasthenia gravis. So why do you say this is myasthenia gravis? Because of history. Okay. Because of, if you look at the EMG, there is a decrement after repeated stimulation. A decrement in the amplitude. This is the very, very pathognomic of myasthenia gravis. Even Lambert-Eaton myasthenia syndrome also, you will get same kind of decrement. More than 10% decrement in CMAP, compound muscle action potential, after repeated nerve stimulation. So nerve stimulation test can be of slow and fast type. There are two types of nerve stimulation test. So what we are talking here is slow, okay, and there will be more than 10% decrement, and the diagnosis is clear here. Now what is the treatment? That is also just going forward. Another case. So this is the critical patient, and patient is intubated, ventilated. There is no improvement in mental state. There is improvement in mental status later after 72 hours, but he was not moving, and SBT was failing. Okay, patient difficult to wean off. So what happened? Then there is a marked proximal weakness in all four limbs. This is the examination finding after critical illness. So diagnosis, I think all have answered well. The diagnosis is critical illness polyneuropathy. Okay. Polymyoneuropathy. So why do you say neuropathy? Because nerve conduction velocity is reduced, amplitude is reduced, and there is a delayed, pattern here. So both delay and both, suppression in the voltage, both are there in NCV. So which is suggestive of neuritis, neuropathy. And EMG is also showing something which is called a spike potential. So this year you have to study a little bit of nerve conduction, study electrodiagnostic testing in neurology. Okay, so that is very interesting, very like grossly you need to know about the electrodiagnostic test. So there is critical illness polyneuropathy. So what are the management? What is the management in case of critical illness neuropathy? The diagnosis is very easy to make, but you need to know the differential diagnosis. That is very important, so that you can rule out other causes of weakness in ICU. And second thing is the management, which is more important. You have to do something to prevent further damage to muscles and neuron, and to improve or to regenerate or to recover. So for that you have to have a physical and occupational therapy team. Tight glucose control with insulin is what they say helps a lot. Stop steroid, stop nephrotoxic medications as early as possible. So all these things help in critical illness polyneuropathy. So that's all. I think I could complete in time, a little bit, just 2-3 minutes ahead of time. Okay, thank you so much.